This conference will now be recorded.
Okay. Sorry about that.
So welcome everybody to AnCan Advanced High Risk Prostate Cancer Group. I'm Herb Geller, as many of you know, and I'm the moderator tonight. And it seems like we have no new people. And so it's really a chance for us to talk to each other. And before I continue, I'll welcome Wang Gao. How are you tonight? She just joined us.
Gao Shan.
Oh, Gao Shan, how are you?
He muted.
You're muted, Gao Shan.
He dutifully muted.
Right.
I know that Gao Shan. Are you with us, Gao Shan? I know he's in the middle of radiation treatment, so you might want to put him in and talk to us.
Okay. That's easy. Oh, okay. So why don't we start? And actually, Carl, why don't you tell us what's going on?
Before you do that, I just would like to acknowledge Jimmy G, who's practicing to come visit me in close to the border here. Must be very sunny in DC. Oh, he's turned his. There he is. There. Nice sombrero you got there, Jimmy.
I'm coming. He's a couple weeks late for Cinco de Mayo.
Yes, yeah.
Well, I had my margarita for Cinco de Mayo.
Oh, good. Okay.
I like to keep it festive around here. I do what I can.
Okay, thank you. You're gonna play a little mariachi for us, Jimmy?
I need money first.
Oh.
You're no better than all these guys in Tucson, man.
Always charge a fee. That's what my daddy said.
Okay.
Hey, Rick, you sure you're not going to be embarrassed being seen with Jimmy in that hat when he comes down there?
I know. I think he's gonna wear it for the marsh, guys. We'll remind you next week, but Jimmy's gonna be with us for the marsh show on the 28th of May. So wow. He may be practicing his headgear for the marsh.
Please come. You may enjoy that. I'm rehearsing for it.
Okay, thank you.
Terrific.
You ready for
actually,
me?
The weather will be 90 degrees here, so the hat is going to be perfect in the next couple of days. The weather will be perfect for that hat. Right. Yes, Carl, I'm ready.
Okay. Those of you who have been following my saga, especially a continuation of our discussion from last week's meeting, and the input that I received from several of you participants, including Rick and Herb and Len, and those people who raised their hands that they've done chemo, and Peter. So the next day, as some of you do know, I did send an email to my oncologist, basically summarizing that what was discussed, and that it appears to be a next viable treatment option for me. Kind of interesting. I haven't heard back from my main oncologist, Dr. Soraya at Rutgers, other than the fact that his scheduler had scheduled a in-person appointment for this coming Friday. So I'm sure we'll discuss this topic as well as some possible other treatment options. One person so far that I have heard back from is Dr. Mark Stein from Columbia Presbyterian. He had emailed me that he would like to talk to me, and that and I wanted to read his response before I had my discussion with him on the telephone. He said that I will do my best to convince you not to take chemo at this time. Can we talk later? So we had a discussion, and he is clearly in the camp of me continuing my saga for seriously considering the clinical trial that is available at Weill Cornell, and more specifically the lutetium 177 in combination with 1 or 2 other drugs. And I know Dennis had mentioned he was going to have an update, so I would assume that Dennis, you'll be giving us a little bit of an update of your experience with the PSMA type of trial. I spoke with Dr. Stein for probably about a half an hour, and he was explaining all the reasons why. He said, you know, at this point in time, it's just not a viable treatment option for you now. That my disease is under control based upon the recent scan results, although the PSA has risen over the 8 weeks that I was on that prior trial of the ARV-110. It went from 4.3 to 9.8 in 8 weeks, so more than double in just 8 weeks. And but he said, well, how are you feeling? Okay, well, that was a good question. And I said, you know, I'm feeling okay. Do I know, or does anyone know that what the possible side effects or the serious side effects of having cancer are? Well, there could be some possibly, and that reminds me of my mom who passed away of kidney cancer. She had been dealing with it for about 7 years, and she had said to me on multiple times, she said, but I'm feeling fine. Well, but she was having, she was dealing with kidney cancer. So that's where I'm at now. As I said, I have a in-person meeting on Friday with Dr. Soraya, and I do have a meeting with Dr. Tagawa on June 1st. And so that's where I am with that.
Well, that's interesting. I mean, you know, I did go to a talk today on DNA damage and DNA repair, and one of the things that came out of all this talk, which was quite interesting, from a guy at Cambridge, said that all of these drugs are, and we've talked about in this group before, that all of these drugs are mainly being tested as 4th, 5th, 6th line drugs after everything failed. But after they are approved, they get used earlier and earlier and have more profound and more significant effects. So, I mean, this may be a case like that, Carl, although I don't know. Again, it's radiation, like any other radiation, it's just delivered a little differently. So it'll be an interesting, you know, you may want to consult with others as well, you know, about this, because I think, you know, at least what I sent you from the talk I heard was that after olaparib stops working, it may be that cisplatin has a real advantage. But
Yeah,
it may depend on
I also did find an article on the internet talking about after the failure of PARP inhibitors, what's next, and it's specifically relating to women who have BRCA2. But you know, it's kind of close, not exact. And that article said that the next possible item to consider or treatment to consider is a combination therapy with PARP inhibitors. So that's something that'll be on my list to discuss on Friday.
Right, right.
Carl, I have a couple of questions. What exactly is the trial that Stein thinks you should participate in with Tagawa?
I have it here. Okay, and he did not mention anything that he's doing, and he's doing a bunch of them as well. And as you may recall, there was a Regeneron 5, 6, 7, 8.
Just tell us. Let me interrupt you. Just tell us what is the trial that Tagawa's mentioned that Tagawa's doing.
In his email to me, he mentioned 2.
Yeah.
One is the AC225 plus lutetium 177, and then he also says something I and T. I don't know exactly what that means. I know it's supposed to be a triple therapy. I don't know what I and T is. And they said that the other one is also, again, AC225 plus pembrolizumab plus hormonotherapy, which would be enzalutamide.
Okay, so what is the ligand? What is the ligand or the antibody that is with the AC225? It would say something like R2 or R617 or
Yes,
J.
he does say J591, if that's what you're
That's what
referring.
I think the only one they're making, Rick, is J591.
So let me just tell you, and I'll be happy to forward it on to you, that Bryce Olson is doing J591 with Actinium 225, and he's having a hell of a time. His side effects, he says, are the worst that he's ever been through. He feels that it's related to the fact that it is a large body molecule, and I can send you the correspondence. I know that he's been corresponding with Dennis. It doesn't seem to be anywhere near as benign as the lutetium with the R2 or the R617. And based on what he's writing, I mean, I'd be happy to connect you to him directly too, but based on what he's writing, and Herb saw this today, I'm not sure I would advise anybody to go into that Actinium 225 until they've got it tied down better. They're still playing around with the doses. They really don't know what to do, and he's miserable. And after the first, this doesn't necessarily mean anything, but after the first line of treatment, and he's coming up for his second, he hasn't seen his PSA go down, although a lot of times we know it takes 2 treatments to have a significant impact. So that's my first concern, and I want to feed that back to you. The second thing is that I know on the NCCN, because it spells it out, that's standard of care. And my question to Mark Stein would be, what makes you think that the trial is better than standard of care? Now, a lot of times we know that trials can be better than standard of care. That's why we do them. And we know enough about standard of care that we look for something better. But in your case, we've seen men respond to standard of care, which is a platinum-based therapy. And if Mark Stein feels so strongly, I'd like to know what his evidence is against standard of care.
Well, he clearly said to me that he has put many patients on chemotherapy, and he would not recommend it for me.
How many of those patients have been BRCA positive, and how many of them has he put on with carboplatin? Did you ask him?
No.
But Carl, you got to be thinking about this stuff, man. I mean, this is you. We're not talking about regular chemo. We're talking about carboplatin, and we're talking about BRCA. And he may be right. Although you can say we've seen guys who do very well. Look at Ken Anderson, 17 in his second round of chemo, 17 sessions, and he's tolerating it. He's not BRCA positive. But you know, I question Stein. And I question him on the basis of where his evidence is for a BRCA positive man who's failed, who's failing olaparib. And you know, it does concern me when he says, well, we got your disease under control, because your doubling time suggests that it may not be under control, and we're better off to nip it in the bud now, because we don't want to be dealing with it when you're at 200, when your PSA is at 200. So that's my input. You have to do what you have to do, but I would be going back to Stein and saying, how many of the men that you have seen you've put on chemo were BRCA positive and had failed olaparib?
Right, and specifically, what's your experience with cisplatin in that situation?
Carboplatin,
Well, it's a platinum-based drug, right?
platinum-based
So-
drug, platinum-based drug. And the person I think I would rely on, ironically, is probably Pam Munster, because she's probably seen more BRCA-based treatment. And, you know, we're at a point where the driving force in your disease is the BRCA, and whether it is breast cancer or prostate cancer or pancreatic cancer, it's the BRCA that I would be focused on, rather than the fact that it's prostate cancer. Because your prostate cancer just doesn't, we know it's not responding to androgen receptor therapy because you failed the ARV110. So, you know, now we throw you over to a PSMA trial. We don't know what the BRCA is doing to the expression of PSMA in your case. What we do know is that the platinum-based therapy will impact a BRCA-driven tumor.
Okay,
Carl?
in regards to Dr. Munster, I have had several discussions with her, both as a telemed appointment and via emails. And in every single case, when I brought up my particular situation, and despite the fact that I'm also BRCA2 positive, she clearly has said to me, I'm sorry, but I really can't help you because I don't deal with men who have the BRCA2 mutation. Even though I'm at the Center for BRCA2 Research, I have very little, if any, experience with men with BRCA2.
Okay.
But then I think, Carl, what we need to find is somebody who has.
I would love to get suggestions because I've been trying to find that,
Yeah, I think
that
I'll try
person.
to do some research. Rick will try to do some research. I think this is you need some other input here. And as much as I know you've talked to 62 people, in this case, I feel like a little more wouldn't hurt.
Sure, thank you.
Carl,
So-
did Dr. Stein say that he wouldn't advise you to take chemo because it wasn't effective in his experience, or because of the side effects, or he wasn't clear on that?
No, he just said that it is definitely an option, but not at this time, that we should look at it at some point in the future, but not now.
So he didn't feel that your disease burden was heavy enough to begin chemo. Was that basically it?
Right, and my scans show, you know, ogliometastatic. My the lesion by the 7th rib has gone up by, as Dr. Tagawa has said to me, has increased by 20%, but it's still a small lesion, and I don't have any side effects that would warrant any type of radiation in that spot.
Well, Carl, I think Rick will forward you the correspondence from Bryce, which is clearly going to be quite informative to you.
Yeah,
Great.
I'm doing that right now, actually.
And I think we can continue offline as we have.
Yeah,
But
thank you.
But I wish I had a clear answer, and I wish we did, but we don't. But
And
maybe Dennis, why don't you tell us more about lutetium?
Let me just say, Herb, if you want me to hook you into to Bryce directly, I can do. He may have some insights into, because he's so knowledgeable scientifically, he may have some insights into this BRCA-related issue. But take a look at this first and get back to us, okay? It's on its way, Carl.
Thank you.
Rick, did Bryce get back to you? Because at the point you copied in Herb and myself and maybe a few others, apparently you hadn't heard from him in a couple of weeks, and he had by that time completed a few more cycles.
Yeah, he got back to you. He got back to me. I'll CC you on. I think this has the. I think this probably has the rest of today's correspondence on it, Len.
Okay, thanks.
But Dennis, tell us about lutetium.
Sure. So the lutetium trial that I'm participating in is lutetium-177 with an R2 ligand. My protocol is 3 treatments, 6 weeks apart. I've had 2 treatments. First one was in March. I'm now on week 11. My final treatment is next week. And this week I have scans on Wednesday. These will be the first scans since I started treatment. And they're 2 conventional scans. It's going to be a CT scan and a bone scan. Next week I'll have a PSMA scan.
How are you feeling?
I feel okay. My side effects have been within the first week of treatment, similar to, not as bad as when I had docetaxel, but there's a fatigue level and a kind of a loss of stamina. But it gets better as the radiation wears off.
And how are your blood counts?
Blood counts are okay. They're within range.
Great.
They have not gotten worse from where I was pre-trial.
I mean, one of the things we can share with you, that Rick and I can share with you, is that in the message from Bryce, his blood counts have just been hammered. It really has made a major effect. He's taking actinium with a different linker, J591. So actinium is an alpha emitter, you're taking a beta emitter, but you're having very different experiences. Have you had a PSA measurement, Dennis?
I did at week 6, right before treatment, and I did get a PSA response.
Okay.
So yeah, so it was good.
So where was your PSA and what's it gone down to so far, Dennis?
Yeah, so when I started trial, the PSA was at 99, and when I got tested at week 6, it was at 50.
Very well. It's
So
a good start, but and week 6 was after how many treatments?
One treatment.
Okay, so and when do you expect to do a PSA test again?
I believe it'll be the day of treatment next week.
Okay, well, everybody's keeping their fingers crossed, and let's hope that it's down a lot more again.
For sure.
Thank you.
That's great. It's good news to hear. So, I mean,
Dennis,
I'm really glad to hear that the side effects are not bothering you.
Dennis, that 50 was that was right before you had your second treatment, right?
That's correct.
Yeah, I mean, the reason I'm asking is because some of the people seem to think it takes 2 treatments to have an impact, but in your case, it was really 1 treatment and it had an impact. That's why I'm following up.
Great. Well, thanks, Dennis. So, Frank.
Any other questions from the group?
Where are you being treated?
University of Wisconsin in Madison.
And what's the name of the trial?
I think that goes by the name of PROTER, P-R-O-T-E-R. It's being run by Novartis and AAA.
Yeah, just to clarify, AAA stands for Advanced Accelerator Applications. They're 100% owned by Novartis, and they have also absorbed Endocyte, which makes the another ligand, which is 617. And it is a small molecule as opposed to a large molecule, and it's also a beta emitter. The lutetium is what's called a beta emitter as opposed to a alpha emitter. Dennis, have you talked directly or just been in email communication with Bryce?
I've been in contact with Bryce since he started the trial by email and text.
Okay.
And we spoke prior to him enrolling. We had a long conversation about my experience. At that point, I had only had one infusion.
Okay. So, I mean, I think that for the people on this call, the take-home message that I'm hearing as of today is that the nature of the radionuclide, whether it's an alpha or a beta emitter, is very significant, and the nature of the molecule that carries the radionuclide to the cancer is also significant, whether it's a small molecule or a large molecule. And this stuff all gets a little complicated, and I'm sort of at the limit of my pay grade, but I think Len and Herb probably understand it better. But these are really, really important factors, certainly in terms of side effects.
Right. I mean, you'd have no problem with the dry mouth or anything like that, Dennis?
I would say a little bit of dry mouth the first week after treatment, but only in the morning. So I've been very diligent about drinking a lot of water, knowing that that can be a side effect. And of course, going a full night with not drinking, you do wake up with a dry mouth, or I do. I don't think everyone has those symptoms, but I do. And it's very manageable.
So are there other questions from the group about lutetium for Dennis? Okay, thank you.
Thank you.
So Frank, would you like to tell us what's going on?
Last week I had mentioned that I finished my last treatment and went in for my scans. The side effects, I'm 4 weeks out from my sixth treatment, a chemo treatment, and the side effects are disappearing gradually, and I'm getting some taste back, and feeling not as much muscle weakness. I did hear, I mentioned last week from the scans, the nuclear bone scan came back clean, which was excellent, and very pleased with that. I got the results back from the other 2 CT scans. One was good and one was a bit mixed. On the 1 CT scan of the abdomen and pelvis, everything, liver, biliary, pancreas, spleen, adrenal glands, kidneys, pelvic organs, bladder, GI tract, lymph nodes, vessels, bones, and soft tissue all came back negative. On the lungs, which concerns me, and I want to put out the question to the group, is my chemo treatment was aimed directly at the 3 nodules on the lungs. with the CT scan, they found that the 3 nodules were exactly the same size as back in October. They didn't go down in size, but they also didn't grow or didn't multiply. So my question is, if the chemo and all the effects of it were aimed at the nodules and it didn't impact them, what does this mean? And what will be the next step? I meet with my oncologist tomorrow morning at about 7:45, and I'm going to be presenting this question to him, is what's the interpretation of the chemo treatment?
Is there a PSA or any other thing that we can correlate with the CT scan?
I have my blood draw tomorrow morning before my appointment with my oncologist.
Have
And I'll
Frank,
get
have you had intermediate PSAs during the 6 courses of therapy?
yes, and the PSA continues to go down. The last PSA was 0.16, and it started at 2.82. The last time my testosterone was measured, it was at 15. And they're going to be measuring it again tomorrow with the blood draw, and I'll get updates on all my blood counts and the test, the PSA and the testosterone. So
Frank,
Frank, I have a question for
you
you.
know what I would be asking? I'll come back to Jacob in a second, but I know what I would be asking. I would be asking what is the likelihood that those nodules are not related to prostate cancer? I mean, it sounds like to me they're not. And the only way we're going to know that is through probably an endoscopic biopsy. But I mean, it sure sounds to me like with the PSA going down and everything else disappearing, that those nodules may not be prostate cancer. And how can we establish that? That's what I'd be driving at.
well, I did have, if you remember, I did have the needle biopsy back in October, which was ordered by the oncologist, and it came back that it was metastatic prostate cancer.
All right. Okay. And did you have that biopsy analyzed?
And I don't understand the question. They read the biopsy, and it came back specific that it was prostate cancer.
Okay. Sorry, I didn't phrase the question very well. Was that biopsy sent off for next generation sequencing? Did you have genomic sequencing done on that biopsy?
I don't have that answer, but I will ask that tomorrow.
So I think that what I would want to do, because you're eligible for it, is I would be sending that off to somebody like Foundation Medicine, and have them analyze it, and let's see if there is a mutation in there that would suggest that it's not going to respond that well to a taxane-based therapy. And if they have the sample, well, they will have the sample, but with that soft tissue sample, you're going to get a very accurate next generation sequencing result.
Well, then I will definitely bring that question to the oncologist tomorrow morning, because I know that Well, a couple things. I know I've read up on a couple things about freezing the spots. I've read about ablation of the spots. I'm not sure about spot radiation. I know I'm going to be asking those questions. Or the second thing, if they haven't increased in size and it is verified that it is prostate cancer, does it warrant just watching it, since it hasn't increased in size, watching it with periodic CT scans to see if it starts to grow again or if it shrinks at all?
I mean, I think those are all viable strategies, but since you have the tissue sample available and it's easy to do, it might well be worth sending it off. Now, you know, we know, I mean, here's where there's a sort of slight puzzle in my own mind. Pete Nelson up at University of Washington did some studies about 3 years ago. And he told us that most metastatic prostate cancer is homogeneous. In other words, unlike other cancers, doesn't matter where you take a metastatic sample from, it's probably going to have the same characteristic. So you would think if you responded in other places, you'd respond in your lungs, but there's always the exception. And it wouldn't hurt, especially if you never had any next generation sequencing done, to send that sample away. And if it was me, I think that would be my first step. Jake, you had something you wanted to say. What was on your mind?
Well, yeah, you actually kind of touched on it, Rick, much more eloquently than I could have. But what I was going to suggest to Frank was that, and of course, then he confirmed afterwards that they did do a biopsy on the nodule in his lungs, and confirmed it was prostate cancer, because something that a nodule that does not grow in size or shrink can often be what's called a benign cyst, that it's very difficult to distinguish on an X-ray or on a scan. I just want to make sure they've ruled them out. You can get cysts from a lot of different things. I've had several myself that they thought were cancer and they're not. So that was my thought. Have they ruled that out, Frank, that they're not cysts? They definitely are cancer.
Yes.
Okay. That's all I had.
Yeah,
Thank
it
you.
was the biopsy was definitive when they took it.
I mean,
Yeah,
I mean, you could always get that. You could always get the biopsy reread too by Epstein, just to rule it out.
Well, I think you bring up a very important point about the sequencing, the genomic sequencing, and I need to ask that specific question because, again, the whole thing in my mind rests if the nodules didn't respond to the chemo, that says something about the nodules, and what specific conclusions can you draw from that? And I think you mentioned it could be through the sequencing that it, even though the biopsy said it was prostate cancer, could it be still be benign?
yeah. I think, I mean, to me, the issue is you've got 3 nodules. They didn't change after chemotherapy that clobbered your PSA. So either maybe they were wrong initially, or as Rick says, maybe they are harboring a mutation that made them resistant to taxane. And I think sequencing is going to help you figure that out. Because if they sequence and it turns out to be not cancer, that's going to be obvious too.
I'm putting a couple of links in the chat window if any of you want to see, read about this homogeneity of metastatic prostate cancer. One is an article from the Fred Hutch magazine, and the other one is a journal article. So
Great.
just so that everybody can see where I got that information from.
I've always heard, guys, that that therapy doesn't necessarily kill things right away. I mean, sometimes there's a lingering effect. And I mean, if you just finish chemo or just finish radiation or something, you don't sometimes get results right away in terms of shrinkage of tumors, tissues, or death of cells. Sometimes it's residual. But what do I know?
Hey, you know a lot. But I think,
I don't know if you can expect, instant results. I'm done with chemo. I should not have any tumor tissue, but I'm not. I think it keeps going for a while.
so I think the answer is let's hear what your doc says soon. And Frank, I think you've got a lot of questions to ask him.
Yes, it should be an interesting discussion.
Frank, make sure you write those questions up and give him a copy.
Sure. Yeah,
Okay.
I did that. I've done that a couple times with him, and with both his nurse practitioner and him.
Right. This is the guy. What's his name? It begins with an M, doesn't it? What's his name?
Mortazavi, Amir
Yeah.
Mortazavi.
Yeah, Mortazavi. Right.
Yeah, and as I've said before, he's been very receptive to the discussions that we have had and the information I brought back to him from the discussions of the support group, and so he hasn't resisted that. Been very open, and I would expect he'll continue to be that way.
In my dreams, I have these nightmares where all these GU medoncs have like gathered together in hordes, and they're all descending down on us moderators of this group with scalpels and goodness knows what else.
Right.
Yeah, just make sure you have your armor on.
That's right.
Any
I got a
other
question.
questions? Sure.
I have a quick question, guys. Does that term next generation, does that refer to the first generation as the primary tumor and the next generation is the metastasis, or does it refer to it's a sort of a updated version of genomic testing? What's that mean?
Right, exactly. Next generation sequencing refers to the latest methods of sequencing DNA. So NGS is the current high power mechanism of sequencing RNA and DNA.
Gotcha, thanks.
I have a question for Frank also, Herb. Frank, when they did your biopsy on the lungs, did they warn you at all about possible lung collapse?
Yes.
They did, okay.
Yeah, they did before actually probably twice or three times before they started the process.
Okay.
Frank, there is one other way. It's a little extreme, but there is another way that you could check this out, which is you could hop on a plane and go to Los Angeles and do a PSMA scan and see if those lung nodules come up as prostate cancer if they're expressing PSMA, assuming you express PSMA, because you get it for free, man. You get a PSMA test for free in Los Angeles right now.
Now with my PSA, down to 0.16. Will that affect the PSMA?
I think what I would do on that score is I would probably write to the PI and ask him what he thinks, and Joe can help you. Joe Gallo can help you do that, because Joe is literally either just arrived or on an airplane on his way to West LA in order to get the PSMA scan tomorrow. So what I would recommend is, wait until Thursday and then reach out to Joe Gallo. And he knowing Joe, he's probably made friends with the PI, and he'll be able to tell you exactly how you can get an answer, because you raise a really good question. The fact is that if you have nodules, I mean, usually men don't have any metastasis with a PSA of 0.2, and that's why it doesn't show. But we know it's showing something. So I would think that the fact that you're less than 2 is irrelevant in your case, if in fact that's prostate cancer, because it would show up. So it's kind of like a double check. What do you say, Herb?
I agree. I mean, your total PSA doesn't mean much at this point if those nodules are the main source, right? If you're saying, do we want to determine if these 3 nodules are PSMA avid, and you're not trying to determine overall where you have metastases. So I think it's a reasonable use of the technique. And it may be giving you the real answer we need.
Can you post in the window Joe Gallo's email contact information where I can?
I'm just doing it. Yeah, as you were talking, I was writing it in. There you go.
Good brains operate in tandem, right?
There you go. Okay. What was your rank? I forget. What was your rank? I forget.
I got out as a captain.
And so did he. He was a Marine captain.
Yeah. Yeah, mine was artillery, and
don't take any crap from those Marines, okay?
Oh, hell no.
Right.
Too many bar fights with them.
Okay.
All right, thanks, Frank.
Okay, I appreciate the input.
So before we move on, I want to welcome our general, Joel, and ask how are you doing, and would you like some time tonight?
Are you with us, Joel?
You're muted, Joel.
Joel, you're muted, but I'm not sure he's. There you go.
All right. Yeah, my PSA has been going up and down with 3 different labs. And so as soon as I get all this straight, I'll report back to you. I'm about to talk to Anton Arakis. He wants me to take 3 scans, including a PSMA PET scan. And I might be going out to LA also. So anyway, that's the short. So I don't need any time tonight.
Okay, well, keep us in the loop for sure.
Okay, and Joel, I think you just heard, use Joe as a resource, because once he comes back on Wednesday, he flies back on Wednesday, he's going to have loads and loads of information for you.
Right.
I've already talked to the PI out there, and he's been very helpful. He's sending me the paperwork tomorrow. The administration out there is not very good, but he's got a whole bunch of slots open in June. So I'll probably be going there at the end of June for the free PSMA PET scan.
Okay, would you be kind enough to send Frank then your email, because that's really what he needs to talk to that PI. He may need to talk to that PI too.
Okay.
The unusual situation. If you can send it over to Frank, that would be really helpful. And Frank, just mention that strategy to Mordasavi tomorrow.
Yes, I will present that also to him.
Great. Okay. Len, would you like to update us?
Sure. I'd like to talk about shortness of breath, which many of us on various forms of hormone therapy get at some point or other. I've been on and off ADT and receptor blockers for nearly 4 of the 7 years that since I've been diagnosed, on and off. And I started feeling shortness of breath, and there could be 100 different reasons. One, I think, was, well, I'll get to that later. I saw a cardio-oncologist when I was down in Florida. I was referred by the GU oncologist down there. And because of the shortness of breath, and they did a coronary calcium scan when I had a high score of 764. But I also had a nuclear stress test and an echocardiogram, and those 2 were normal. So the only abnormal was the coronary calcium scan. So the cardiologist put me on rosuvastatin, and he said it's not going to bring your coronary calcium score down, but it will prevent it from going up. He also said, I don't think that's really the cause of your shortness of breath. He thought it was from deconditioning, is the exact phrase he used, which kind of made sense because right now I'm up in Connecticut and it's very hilly. And you can get quite a workout just walking up and down the hills. They're pretty steep. Down in Florida, of course, everything's flat and it's really difficult. I can't run because then I get back problems and hip problems. So all I can do is walk. And, you know, with COVID, I wasn't going to the gym. And so it's really difficult, you know, even walking 4 or 5 miles a day, it's not easy to get your heart rate going if you're just walking on a flat surface. So I did a little looking into side effects of the drugs I was taking. And maybe you guys knew this already. I did not. But for Xgeva, it said that one of the most serious side effects is shortness of breath. So I started wondering if maybe I should continue taking Xgeva. And I remember years ago, I was reading up on these bone strengthening agents, and some of them seem to have, I mean, they've been FDA approved, but I'm not sure I recall them making a huge difference in your longevity. But I have to do more research on that. But
I don't think I'm not sure that the endpoint was longevity. I think the endpoint in all those tests was fractures, Len.
Yeah, you're right. Yeah, I wasn't implying that the endpoint was shortness of breath or longevity, I should say. But
you're not on Flomax, are you?
Usually you measure overall survival, right? They put you on something like Xgeva, and there's another group that's on the same medications only without Xgeva, or they get a placebo. And supposedly, if you were on Xgeva, your overall survival or your progression-free survival was a bit longer.
You're not on Flomax, are you?
On what?
Flomax.
No.
Okay.
Well, Lynn, I will tell you, I was thinking the same thing. I have noticed that climbing stairs is not as easy as it used to be. So in order to get to my office, I climb 8 flights of stairs.
8 flights?
Yeah, but I mean, it sounds ridiculous, but the way my building is built, I'm only on the 4th floor but there's a floor between each floor for services. So in order to get to the 4th floor, you got to climb 8 flights of stairs. And I've just noticed that it just ain't as easy as it used to be. I mean, I did it today and I get winded. So, and I've been wondering the same thing, although I do my stationary bicycle in the morning, get my heart rate up really well. So I feel like that's exercise. But I do, you know, I've had the same issue of whether I have some cardiac problem or whether this is due to some of the therapies.
Yeah, so I'm still not sure if Xgeva is the culprit, but just something to think about. And when you think about stopping it, I read that stopping it can actually cause fractures. I don't quite, not sure how that works. And it wasn't clear if they were saying, well, you could develop fractures because you're no longer on the Xgeva, or if they meant the actual act of stopping the Xgeva promotes fractures.
Well, I think what it does, it alters the balance between osteoclasts and osteoblasts.
Oh, yeah.
And then if you take away the Xgeva, it really pushed you in the osteoclast category.
Yeah, maybe it kind of, I was wondering if all of a sudden your osteoclast activity ramps up more than it otherwise would have.
I think maybe it does.
So you kind of trapped, you're like, well, I can't stop taking it. I've got to continue.
Yeah, I don't think it, but I don't think it's good. Somehow I just don't think it's the cause of our issues.
Len, were you going to go to something else? You know, Alicia Morgan suggested I go off Xgeva and go back to Prolia.
To what? Oh, Prolia?
Prolia, yeah.
Well, that's a low dose Xgeva.
Yes.
I mean, so she did say, that's interesting. I'll talk to my doc about that next time I see him. Because, go ahead.
Dr. Kwan suggested the same thing. I just came back from Dr. Kwan. He agreed with Alicia Morgan's.
And was that because of the lessen the possibility of shortness of breath, or?
No, it's something. They both didn't think that was the thing to do. It was an overkill.
Okay, good to know. Okay, so the other important thing applies to anyone on the call who takes darolutamide. I know Peter does, of course. I don't know if anyone else does. And so I told you I was put on rosuvastatin, and then they checked it, and I was put on a low dose, 10 milligrams. It goes up to 40. And in 2 weeks, my cholesterol and my triglycerides and, you know, all the lipid panel markers dropped precipitously after just 2 weeks. Like my cholesterol went from 190 something down to 143. So I thought to myself, something strange going on here. I looked into the package prescribing information for rosuvastatin, and it said that if you're taking darolutamide, it can increase the blood levels of rosuvastatin by 5-fold. So the 10 milligrams I thought I was taking was equivalent to 50 milligrams, which is higher than the highest dose. I didn't have any side effects, but I imagine eventually I might have. So I stopped taking it pending my next appointment with Dr. O. But something to keep in mind if anybody, because a lot of prostate cancer guys are taking a statin, and fewer are taking darolutamide, but that may become more popular. So just something to keep in mind.
I just want to make one quick comment, sort of peripheral, but it ties in with something that both Len and Herb said, which is that even if you're just walking and you feel like you cannot get your heart rate up with the walking, then, you know, the alternative is you do what what Herb's doing, you're using a stationary bike, or you use a rowing machine. But there are alternatives. I just wanted to say that.
Yeah, and I do use those things when I'm at the gym. And I'm thinking of going back to the gym. I mean, most of us are double vaccinated by now. I am. So I think it's time to get back to the gym.
Well, you know, even without the gym, a good way, there are always exercise bikes available on Craigslist or Nextdoor or what have you, because everybody goes out and buys them and then they never use them, and they sit in the basement. So you can always, if you've got room to put one, or an even simpler way, which is what I've got it set up right now, right here, is you put your bike in a trainer and you just sit on your bicycle and pedal. So that's another way to go.
And I suppose, this is John, I suppose that you're not, I mean, all of us are probably mildly anemic. And I looked into the question of whether my mild anemia could be responsible for being short of breath. And the cardiologist thought no, that it would have to get quite low before you were really short of breath. So I'm going through cardiology workup now, and to see if there's a source. I think that if the shortness of breath is, clearly different than the way it was before, then it's on you and your doctor just to make sure it's not a cardiac problem.
Yeah,
Could
exactly.
be an arrhythmia or something like that,
Yeah, and we did have
I got
a
taken
situation.
off of my abiraterone because of cardiac worries.
Right.
While workup is going on, for example.
Yeah, there was what prompted me to seek a cardiologist was that Rick and I know someone up in Canada who was on ADT for a number of years, and he had not only shortness of breath, but near fainting spells, actual fainting spells. And so he went to a cardiologist, and they had to put him on a pacemaker.
Mm.
And there's no history of cardiovascular issues in his family, so they assumed it was the ADT.
I just got one, just something I like to throw in when we're talking about, getting the heart rate up and what kind of exercise we want to do and where we're going to go. And it's so hard for us to want, especially on ADT, it's a struggle, right? To want to work out or to want to work out hard enough, to want to push hard enough. But we don't want to push too hard because there's all these threats at the same time. And I just want to throw in that one thing that's very, very helpful to me, I don't know if it's mentioned specifically or not, is a simple heart rate monitor. So whenever I'm working out, no matter what kind of exercise I'm doing, right there with my phone, got the app right there. I can open and close it anytime, and I can keep track of all, I don't use it, all of its features, but certainly I keep a running, look at how I'm doing, and I find it hard when I'm walking city streets to get my heart rate up unless I really bear down and walk fast. I can do it in woods and hills and stuff, but I would walk with a weighted vest, and that seems to, to do it for me. But regardless, I mean, whatever I'm doing, sometimes I think that I'm really, really working hard and I'm discouraged because it looks like there's not that much, the heart rate's not that elevated. But I find that after I warm up, the more I get warmed up, then the more, once it starts reaching higher and higher. And I know this, but I still like to see it. And then it stays there. And then I have to be careful not to push too hard once I'm good and warmed up. And everything fell from the ADT. Everything did. My maximum heart rate fell. My resting pulse rate went up. My body fat went up. Everything, it's all bad. But that's just one of the things I thought I'd say is that the heart rate monitor is such a great way to keep an eye on what you're doing.
Thanks, Jimmy.
Thanks.
Can ADT Can ADT and abiraterone, can they mess up your lipid profile?
Absolutely.
Yes.
Hugely.
Yeah, your glucose, your lipid profile, diabetes.
Everything. All the metabolic factors.
Is
And
it the abiraterone or the ADT or both?
well, it's both. With apparatus, it's both.
So,
It's
I mean,
both.
keep in mind that your testosterone is important in really helping muscle mass and metabolism and glucose tolerance as well.
'Cause I had my first lipid profile since the early days of ADT and abiraterone, and it was much worse.
Yeah, I mean that's one of the reasons why you should monitor it. And you know, if you're not on a statin, talk to your doc about getting onto a statin. But that's a discussion that you definitely should be having with your GU medical oncologist and also with your PCP. Really important.
What?
Yeah.
And
I mean,
also,
especially if your Gary, if your lipid profile went up, what did your doc say?
I haven't talked to him yet. I just got it a couple of days ago.
Okay.
Rick, who was the other doctor you mentioned? You said with your oncologist and who else?
And your PCP, your primary care physician.
Ah, got it. Okay, thanks.
Anything else about shortness of breath, lipids, metabolism? Let's hear from the guys. If not, we'll move on. Stan, how are you doing?
Doing okay. So it's been about 4.5 months since my initial diagnosis. I started off with the abiraterone in February, and about a month into it, we determined that the drug and my liver just weren't getting along well together. My blood levels regarding my liver were going sky high or dropping. So we suspended, I got off of it for a week, allowed my levels to kind of begin to return. I also got off, interestingly enough, my atorvastatin at the same time, since both metabolize in the liver, the abiraterone and the atorvastatin. I tried a half a dosage for a week, but my blood levels quickly went south again. So after I exchanged emails with Rick, and after a discussion with my doctor, we went over to enzalutamide, which I've been taking now for a month, over a month, with minimal side effects, really. A week and a half ago, I had a nuclear bone scan, a CT scan, and an MRI. My PSA is down now to 0.34. My testosterone is down to 2. My metastases in the pelvic bone area is unchanged in size, but there's some partial healing that was evident. My lymph nodes have gone down in size. My prostate volume decreased about 40%, and my dominant tumor on the gland has decreased in size as well. I also had got the results back about a week or so ago on the genetic profiling I did, both germline testing and testing on my tumor. I had some defects, but none that related to prostate cancer. That's not to say in another year they're going to determine something different, but at the moment, genetic profiling, no BRCA, nothing of that sort. I have an appointment with the radiation oncologist at MSK about a week and a half or so, and he's going to give me his recommendation on subsequent radiation treatment. So looks as though things are going in the right direction, and it just hopefully I'll be able to sustain what's been going on for a good while longer.
We hope, for sure.
Oh, yep.
Any questions for Stan?
Well, I just want to say I'm really pleased to hear that the enzalutamide seems to be working. I mean, it wasn't that you failed abiraterone, it's just that it didn't agree with you, and it's great to hear that the enzalutamide is working and that you feel much better on it.
Yeah, I've had really no side effects, and I know my testosterone level is really low, but I'm not suffering from fatigue. I've been walking 3 miles every day, exercising, etc. Keeping up my, trying to keep up my muscle tone and all of that, just to counteract those effects.
Well, keep it up. I mean, let's hear what the radiation oncologist wants to do.
Sounds right on track. Well, otherwise, huh?
Right. So why MSKCC? Weren't you locally here?
Why MSK?
Yeah.
Yeah, no, I'm in Stamford, Connecticut.
Oh, okay. Sorry, I missed that.
Yeah,
okay.
So my main.
For sure. No, that's the right place. Sorry.
Yeah. So my main, the medical oncologist is down in the city, but they have. I've been going to the West Harrison, which is only half an hour away. If I start radiation, that's where I'll be going. I won't have to schlep down to New York.
Got it. Okay, so keep it up, Stan. Let's hope it continues in this direction because it's really good to hear. Okay, next, James Barnes. How are things?
Hey guys. I'm not sure I have a coherent question, but a week and a half ago, I went to see my oncologist, and tested my PSA, and it was still undetectable, which is awesome. And so that was the second time in a row, and I've been on a combination of either Eligard or Lupron for the last 9 months, and I go in for a shot in a couple weeks. But part of my visit was I had I was experiencing some pain, and the only way I can describe it, it really feels like the very bottom of my pelvic girdle. Oh, it hurts when I'm standing. When I'm sitting, it's okay. When I'm laying down sleeping, it's okay. And went through that with the doc and everything. And it's very close to my rectum, and the just trying to figure out what's going on. And so doctor's going to do a MRI here in the coming weeks. And so I just wanted to throw that out there. And I guess part of my question was, since it seems like it's sometimes an intermittent pain or different positions, would the spread of cancer be more consistent pain than that, constant pain, if it actually was the bone in the pelvic girdle? I had kind of had that question. I just wanted to throw out there. And any other thoughts or advice anybody could give me? And then the second part of my complaint, when I was there, I was not tolerating the second line ADT, the enzalutamide, well, getting really severe fatigue and mental fog and that sort of thing. So he said, well, let's stop taking that for a while. So I'm got a little mini drug holiday on not having to take enzalutamide. But my argument to them was you put me on Eligard and Lupron, depending on what was available. And, then you throw this enzalutamide on top. Well, how can you tell if I needed enzalutamide if the goal is to have ADT to get my testosterone down to 0? Why isn't there, a test before doctors are administering enzalutamide or abiraterone as a second line ADT? And, it's just, and the only answer you get back is, oh, it's standard of care. And, I just don't feel like that's solid science. And I just want to get some, any thoughts or feedback on that as well.
So the first question I have actually is based on the pain. Does it respond to ibuprofen?
I don't know. I never took any. Actually, they did give me a prescription for oxycodone, and it did respond to that.
Well, codeine is, I mean, that's like overkill, right? I mean, you want, ibuprofen is really, a non-steroidal anti-inflammatory. And I have found, and I think other people say that if, that's a good indicator of whether it's going to be bone pain or inflammation. So 400 milligrams of ibuprofen might give you some diagnostic information.
Which way's which? If the pain goes away with ibuprofen, it's cancer probably wouldn't respond to that.
No, if it goes away with ibuprofen, chances are it's inflammatory based. I mean, the problem with oxycodone is it's going to clobber everything. I mean, that is a drug of last resort. I'm kind of very surprised you got it. We all take Percocet once in a while, and it makes us feel great, but the consequences are terrible.
What are the consequences?
Of Percocet, of opiates? There's a big addiction possibility.
Okay, gotcha.
Now, Herb, I asked my doctor about that. This is Jake. I've been on oxycodone off and on for years. Actually, I take one every day, and lately I've been taking 2. But I told her I was very concerned about being addicted, and she said that with cancer pain, cancer patients seldom, if ever, get addicted to opiates.
Yeah, but we don't know that this is cancer pain, Jake.
Well, true. In my case, it is, but yeah.
I mean, my suggestion is to take something that would not touch cancer pain and see what happens.
I think that's good advice.
And then getting back to your second question about why enzalutamide, I think it is guidelines. It is now standard of care in your situation to use a second generation anti-androgen. Now, if your PSA is 0, others in the group can probably address if there's time to take a drug holiday. I can't address that. But maybe Len, you can say something.
Yeah, I would. How long have you been undetectable, Jim?
Probably 6 months now.
I definitely talked to your doctor about going on drug holiday from enzalutamide, even if you want to stick to the Lupron. And that, you talked about the brain fog. Of course, the opiate. Did you say codeine or oxycodone?
He said oxycodone.
Oxycodone. Okay, yeah. Well, of course, that plus the enzalutamide, I can imagine, would send you into a foggy brain state. So at least eliminating the enzalutamide might help.
So they didn't give me I didn't get the oxycodone until I went there complaining about it, and then that's when I stopped the enzalutamide based on my complaint of brain fogginess prior to taking the oxycodone. So, yeah, so that's, no, I was just, I mean, and, you know, I don't know, does everybody take the same amount of Eligard or abiraterone? I mean, I'm taking 4 pills and, you know, a night that are 40 milligrams each. And, you know, I'm just wondering, is that a standard dose that everybody takes?
Hold on, time out. If you're taking Eligard or Lupron, that's not a pill.
No, of course not. No, I said, did I say, I meant enzalutamide. The enzalutamide, I take 4 pills of enzalutamide every night. Each one's 40 milligrams.
Okay.
Right, that's what I'm taking.
Yeah, it's not uncommon that if you're not tolerating the enzalutamide very well, you're getting that extreme fatigue, that they will suggest you cut back on the dose. We hear that.
Okay.
So
What about darolutamide?
I just want to say a couple of things here. I wouldn't recommend going off hormone therapy and taking a holiday until you've been on consistently for a good 18 months. Now, I realize you're not talking about that. I realize you're talking about staying on some type of hormone therapy, but maybe not both the drugs. So if it were me, I would not go off for at least 18 months, if not 24 months. And I think we're consistent in that position now.
You mean totally, or are you saying you wouldn't go totally off?
Right. I would not go totally off hormone
I agree with that.
And I understand you're not saying that. Okay. I understand you're saying you're just going to stop the enzalutamide, but it raises another issue that some of our men have tried monotherapy with just the second line anti-androgen. So right now, Len is just on darolutamide, and it's keeping his cancer down. And Ken Anderson is just on abiraterone, and it's keeping his cancer down. So, you know, they're pretty unusual strategies, but they may work. So the issue is, you know, if you want to try something different, just try one. It could be the LHRH, or it could be the second line anti-androgen.
They told me that I would probably be on ADT the rest of my life without any break, without any holiday.
Yeah, I don't like it when they say that, personally, because I don't think it's the case. And we've seen enough men with success on with intermittent treatment that's no longer the case. And also there is the possibility of doing a monotherapy second line anti-androgen, which may be beneficial to you, like Len is doing. So relinquish that statement, don't embrace that statement, and let's see where we go with you. And you know, once you've, how long have you been on the Lupron?
That was my last shot that I got 3 months ago, and I'm going to go in for. I requested Eligard because Lupron was too painful.
Okay, how long have you been on Lupron or Eligard? When did you first start it?
I just completing 9 months, and so
okay,
went in for a 4th shot.
I would say, you know, talk to Jim Ward. He's a, you know, we convinced Jim to stay on for 2 years, and he did, and now he's on intermittent, and he had de novo metastatic lymph disease. I think you had de novo metastatic, as I recall, you had de novo metastatic bone disease, right? Wasn't it in your bones at the outset?
Yes.
So, you know, the old philosophy was, yeah, you're never going to get off of it. But I wouldn't, I don't know, would other people agree that Jim Barnes is never going to get off hormone
How can
therapy?
we tell? There's no data. I mean, Jim, the point is, who can, it's like the people who say, well, you've got 9 months or whatever. It's all, how do they know? Right? It's all a matter of looking at your current situation and saying, you know, let's look at the data and let's decide what the appropriate therapy is. Not to try to say what it might be in 2 years.
Right. Well, originally, he had suggested intermittent ADT, and then as we went down the road and they found more spots on my spine, he said, you're likely going to be on ADT the rest of your life. So, I mean, the Eligard isn't too bad, but the combination of the Eligard and the enzalutamide just constantly, I mean, was too much. If I skipped a couple days, I felt much better.
So what about darolutamide?
I don't know.
Len?
He's metastatic, Herb. I think. Didn't he just say you're metastatic?
Correct.
Yeah.
Yeah, that would be a challenge, I guess, for his med-onc to convince insurance companies to cover it. I mean, it's been done. It was done for me. It was done for others. When you were diagnosed, oh yeah, you were metastatic. Okay. Were you?
Enzalutamide ain't cheap, right? I mean, none of it's cheap.
I think didn't enzalutamide go on generic?
No.
No. Oh, yes,
Abiraterone is generic. Abby is generic.
Right.
But like Rick said, and like I mentioned, guys do cut back on the dose of enzalutamide in particular, and even sometimes abiraterone, because they're just not tolerating it very well. It might be a good idea to talk to your doc about it. What's the worst that can happen? If you start to see your PSA rise, then you go back to full dose. It'll be fine.
Yeah, I think that's the plan.
And who knows? It could be that like a half dose of enzalutamide for you works as good as a full dose does for someone else. Everybody's different.
My question was more about the science behind that, and no, I appreciate all that feedback. That's very helpful. But it's like they don't test your testosterone after you're on Eligard or Lupron for a while to say, okay, did we cross the finish line? Did we get where we want to be with testosterone? And oh no, that didn't quite get us there. Now we're going to try abiraterone or enzalutamide. It just is like, no, throw another hand grenade at it.
Well, the Stampede trials did test it, and they found that for men with multiple, with high volume metastasis, meaning more than 4 or 5 spots, that the right way to go was first of all, to start with chemotherapy. If you had low volume metastasis, the right way to go was with a second-line anti-androgen. So depending on the number of spots you had, there was evidence, assuming that you didn't have more than 5 spots, there was evidence to start with either abiraterone or enzalutamide.
Yeah, Jim, when you say, well, standard of care, what does that mean? What about the science? Well, standard of care is always based on the science. It's standard of care because they've run clinical trials and they've shown that, statistically it works better than not.
I get it.
But I certainly think that if, it may be that if your PSA is 0 or not measurable, cutting back would not be an outrageous decision if it's really bothering you.
Isn't it true that the reason that the second line anti-androgen is given alongside the Lupron or Eligard. In my case, on a clinical trial, they gave me both right away, and they consider it to be total androgen blockade. So their purpose was to drive the testosterone lower than it would have been with Eligard, or in that case, Lupron alone. And when I got that, my testosterone was under 10 the entire time I was on the trial. And I've heard other guys, I've read stuff where if it's driven down to 40 or 35, that's not as effective as it is when you drive it down. You want to drive it down as low as you can. And I think that's why they throw the second line on top of that. Is that not right?
Well, the second line actually does not affect your systemic testosterone, right? So in the case of abiraterone, it might, but mostly it's there to prevent synthesis of testosterone by other than your sex organs.
Adrenal
Because
glands.
that's where, right, because the LHRH, GnRH axis is really directed against your sex organ derived testosterone and gonadal testosterone. And Abi blocks the enzyme that just blocks all the synthesis. So it is there to block local testosterone. Enzalutamide is there to say any residual testosterone, we want to block it from touching from activating the receptors.
Yeah.
And both of those in clinical trials showed significant enhancement of survival as opposed to androgen deprivation therapy alone. And that's why it's standard of care.
Thanks, sir.
Okay, I think
just to recap real quick, Herb, on the ibuprofen, if the ibuprofen takes the pain away, what does that tell me?
it would be unlikely to my mind to be cancer pain.
I gotcha. Okay, well, I'll let you guys know next couple weeks from now after I get my MRO what's going on. Thank you very much.
Great.
Yeah, Jim, I wanted to make a comment. My doctor told me that when you have cancer pain, it's usually consistent and steady. It does not come and go like a muscle ache. So if you have it constantly, then chances are it might be related to cancer. But if it comes and goes, depending on whether you take a pill or not, then probably it is not cancer related. That's my understanding from my doctor.
No, I think that's right, Jake. 100%.
All right, thanks, Jake.
I think we should move on. Even though there's no new guys, we're still a little slow. Dennis Correa, tell us what's up.
Yeah, I'm still looking at coming off of my first drug holiday on this intermittent treatment. And for Jim, for your information, I was over 2 years at less than 0.1 before my doctor would be agreeable to taking the drug holiday. So I got about 9 months off of everything: Lupron, abiraterone, and prednisone. And now my PSA is starting to rise, and starting to rise fairly quickly. My last check last week, I'm now at 1.7. And I know the order of things here is not really well defined when you're on this intermittent treatment. And I guess Len has probably got the most experience with it for doing this for 4 years on and off. And the first step is to find out why it's going up again. Where is the tumor activity? What's going on? And we've got a couple of options there. I could go back and do an Axumin scan or a PSMA. Now, the Axumin's a lot easier to get, and I think at the level of my PSA is that the Axumin scan will work. And the other curiosity I have about what's causing the PSA, where I was large volume metastatic, and essentially I had reached this nadir point here, and now that's coming back. My assumption, I don't know why I assumed it, but I assumed it would be one of the areas where I had this cancer before where it'd be coming back. But Len, I think you had didn't you get it in an iliac bone or something? I remember you said it had a bone, you had to go and do a biopsy on this.
Yes.
Is that right? Okay.
Mhm.
And so that's where yours came back in a place where you didn't have it before.
Yeah, that's true.
Okay. I think that's very interesting to me. And that's why I think
This way, Dennis, with the technology that was available at the time, there were no bone metastases detected. It wasn't until PSMA PET came along that they were able to detect bone lesions. And even after it was detected with the PSMA PET, I had a traditional bone scan after that, and it was negative. So it's, you know.
I know the bone scan, traditional bone scan doesn't do it, but the Axumin scan does.
I had an Axumin scan too, and that was negative.
It was.
Yeah.
Your PSA was what when you had that done?
0.8 something, 0.85.
Yeah, it's probably why, because that's pretty low. It goes up, the ability to detect goes up as your PSA gets up to about 2, where at least with the Axumin scan, I think that's about 100% detection rate when you get to about a PSA of 2. So I'm almost there, 1.7. At between 1 and 2, it's about 83%. If you're down less than 1, it's like 72% detection rate, I think. So I think the Axumin scan would work for me.
Yeah, certainly worth trying.
So I guess
it's a case of it, you know, what's available to me fairly quickly. And I think the Axumin kind of fits that bill.
Yeah.
Dennis, did you say that you are on intermittent therapy?
Yes. Yes,
So,
but this is my first time where I'm actually have to go back on something.
So the question is, what will the scan do for you rather than just saying, look, let's go back on full time?
Well, because that was my initial thought, that I would just go back on what I was using before that was working for me. But if it's just a 1 or 2 areas, and it might be a bone and in a different location, and if it's amenable to radiation, I get the radiation, and maybe you have to go on the hormone stuff again for a little bit, but not for as long as I would if I went straight back on it, just without the radiation. That's my assumption, I guess. You know, this whole thing is that you're just basically, because it's not a real well-defined standard of care for this intermittent treatment.
Yeah, that's true. It's controversial, you know, whether or not the spot radiation is effective. Some think it is, some doubt it, but like you say, you just have to make your own decision on that together with your doctor.
Right.
Right. Any other comments on intermittent and what Dennis might do?
The only other thing I said to Dennis when he spoke is that if Dennis were to go back on, maybe he might want to try monotherapy abiraterone, the way that Ken is doing it right now. So it's just another alternative. And I'm also encouraging Dennis to consider Provenge, because he hasn't done it, and I do think it's an option that is worthwhile.
Yeah, after what we listened to Larry and what I've been reading, it's something to talk to your doc about.
Yeah.
Dennis, and you know, again, everyone seems to say the earlier you get it, the more likely it is to have a prolonged effect. So I would consider.
I started with, you know, with chemo because I was large volume metastatic. And I don't know if that makes a difference either from a standpoint how well Provenge will work. I've been on this deal for 5 years. So I'm not really new at it. It's not really just starting.
Yeah, but I don't think the sequencing is a factor, Dennis. I think, you know, whether you've been on chemo or not, I've never read any evidence that it's going to impact the Provenge. I don't see being on chemo as a reason not to do Provenge.
Mm-hmm.
Yep.
Herb, you were on chemo. Would you consider Provenge?
Yes. I mean, that's, you know, I am thinking about, even though I don't need it at the moment, I'm certainly planning what I might do next. And Provenge is certainly on the list.
Look, the time to do Provenge is when you don't need it. Seriously.
Yeah.
Yep.
Okay, that's something for me to investigate. Then I'll be doing some more reading on that.
Right. Well, keep us informed, Dennis.
Will do.
Okay,
Thanks.
great. Les, tell us what's up.
Okay, 2 weeks ago, we were on here and I had gotten a lot of information about suggestions on where to go from here. I was going up to Mayo Clinic, which I was last week. That's where I was when I missed. I did get a lot of suggestions, a lot of thoughts, and I appreciate all of them. I just want to report what the finding was rather than my try to explain it. I'm going to read a couple of sentences from Dr. Kwan's final report. Laboratory testing reveals PSA of 0.1 nanograms per milliliter. C11 choline PET imaging reveals no evidence of persistent or recurring or progressive disease. Prompted by today's extremely favorable findings, we recommend that the patient return in 6 months for further evaluation. That's it.
Well,
Nice.
mazel tov. That's great.
Congratulations.
Wonderful news.
That's about as good as we could have expected.
Right.
Yep.
Fantastic.
That's great.
So Les, I can't recall now. Are you taking some form of ADT?
Yes, I'm on Eligard.
Eligard, okay. So they want you to continue on that.
Yes.
Come back in 6. Okay. Yeah, that's reasonable.
That's great.
Okay, that's it.
Okay. Good show. Julian, tell us what's up.
Oh, just a quick update. I had a conference call with my oncologist, and he says that doing the brachy boost would probably be a good idea to talk to Dr. Andrew Farouche this week and see what he says. But they'll be using, I don't know if anyone's ever heard of BMAT. They'll be doing 39, when they start the therapy, they want to do 39 fractions, 25 and 14, 25 of the pelvic area and then 14 of the, unless I have those reversed, of the prostate.
Mm-hmm.
So 39 treatments altogether.
That's if you don't do the brachy.
No, she said she wouldn't mind doing the brachy. It wouldn't make any difference to her.
Yeah, but if you did the brachy, they wouldn't do 39 treatments.
Oh, they wouldn't?
No. If you do the brachy, they won't. She said 25 treatments to the pelvic area and 14 treatments to the gland. Is that what she said?
Yes.
So if you did the brachy, they would not do the 14 treatments to the gland. That would be in lieu of that.
Oh, okay. Okay, well, I have a call with the brachy guy on I think on Thursday.
Okay, so that would be And the other alternative to the brachy is stereotactic body radiation therapy, SBRT, and that's another way to go instead of the brachy. It would be probably 4 treatments instead of 14. So those are all of, so when you have the appointment with this fella Parak, Ray the brachy, ask him about SBRT or brachytherapy, and ask him what type of brachytherapy, because there are 2 different types of brachytherapy.
Right. Okay.
Anyone else on this call? I mean, I know that's what I did. Has anybody else on the call had experience with that combination? Remember, in this case, for Julian, this is recurrent disease. This is not the same as what I had, where it was new disease for me.
Yeah. I don't know. Anybody have experience with, other than Rick, with brachy?
Yes, no.
I mean, if the issue is to destroy the cancer in your prostate, I mean, SBRT versus brachy are pretty well established, both effectiveness. So what I would ask your RO, why one versus the other?
Okay.
Yeah, I mean, to be honest, I think it's largely they haven't really done the testing with SBRT plus IMRT plus HT as yet. The results aren't out on those trials, but you know, if you talk to somebody like Mac Roach, he'll say SBRT today is just as good as doing brachy. So it's really a convenience factor.
Right.
And what type of brachy they're going to give you. And that's a function of how much disease you have, and et cetera, et cetera. So just come back to us. But the whole point, Julian, is this should save you a significant number of trips, and you get it done quicker.
Right. Okay, good question. Thank you.
Okay. Jeff Markey, tell us what's up.
He just left.
I'm gonna have to.
Oh no, he's back.
Well, I have to, when I move from room to room, I have to switch routers, so wireless. So I go. What if I don't switch? The audio goes away. Thank you, though.
You're up, Dave. Jeff. Tell us what's up.
No, I'm gonna pass. It's too late.
It's too late. For who? Okay.
Sorry, I'm eating dinner, so I'm.
All right. Sorry about that. We'll get you earlier next week. Dave Starr.
Yes.
Tell us what's up.
Not much. I think this is pretty simple. I have been off chemo since March, and I'm seeing my doctor currently once every 2 months and a Lupron shot every 4 months. I brought up just before the end of the meeting last week the red legs and the itching thing, and I heard a lot of moaning and groaning in the background. And my question now is, I've gone to have a couple of acupuncture treatments. Do you think that's okay?
Well, do you think it's okay?
I think it's okay.
How are you doing with it?
I've only had 2. I'm going to a lady that about 5 or 6 years ago took away my knee problems, acupuncture lady, doctor of Oriental medicine. My knees were terrible. I saw her about 6-8 times, and my knees have been fine since.
So have you noticed any improvement since you've had 2 treatments?
Not really. But my
Okay.
other symptom, my other symptoms of this prostate cancer, my tiredness, is just about gone. I'm out walking and doing that stuff again. But the red, I wear, like I said last week, I wear gloves to bed so I don't scratch myself to death.
Right.
Right.
You know,
Yeah.
I definitely think, I mean, we can't give medical advice. We're not doctors, but it
That's
sounds
correct.
to me like you're dealing with neuropathy there from your
I
chemotherapy.
asked about that last week. Yeah.
And what did the acupuncturist say? Did you tell her that you thought it might be neuropathy?
I never brought that word up to her. I've only seen her twice now.
Okay.
Today was the second time.
Right. You've got to tell her that it's neuropathy.
Okay.
Because she knows the points to treat for neuropathy.
Gotcha.
All right. If she's treating you for a skin rash, she may be treating you at points that are related to allergies.
Okay.
And what you've got to be telling her is, no, I think this is from my chemotherapy, and I think it's neuropathy. And
I got that written down from last week. I got it.
Okay, well, you try that and then tell us, because, you know, with something like acupuncture, they've got to treat you in the right points. That's how it works.
Right. I understand that.
Okay.
So I'm due to see her next Monday, and I will tell her that exactly.
Yeah. Now, anyone else have any other suggestions for Dave? We talked about neuropathy last week. Any other homeopathic or other suggestions for Dave if it's neuropathy?
I mean, again, we mentioned Neurontin, I think, but
yeah.
So, Dave,
Did you
where
say
are you
Arleta?
located?
Did somebody say
David,
Arleta?
No.
Okay.
Dave, where are you located?
Vegas.
Oh,
Pardon me?
Vegas. Okay. Okay.
Yes, Las Vegas. Yeah.
Dave, have you tried gabapentin?
I didn't hear the last word.
Gabapentin.
Never heard of it.
It's fairly commonly used for neuropathy, particularly diabetic neuropathy. Works for some people, not for everyone.
Okay.
The trade name is Neurontin, Neurontin.
Gotcha. Thank you.
Okay, well, let's see what happens after your next treatment.
Thank you.
Okay.
That's all for me.
I would just say this, that if you can find the solution with the acupuncture, that would be wonderful. If you cannot, then think about the gabapentin, Neurontin as one possibility. And, you know, talk to the doctor that prescribed you the chemotherapy and see what they say about treating the neuropathy.
I got you. Thank you
Another
very much.
possible drug would be Lyrica.
How do you spell that?
The trade name is Lyrica. The generic name is
pregabalin.
Pregabalin.
Yeah.
And they're very similar to
Very similar.
gabapentin, pregabalin are very similar drugs.
Okay. Thank you.
We've written them in the chat window. Oh, you're on the telephone, aren't you, David? I
Correct.
forgot. Yeah.
Okay. Okay, I'm happy.
Good, but I think if acupuncture worked, I would go with that before starting drugs.
I agree with that.
Okay. Okay.
I mean, great.
My
Okay.
my last time with her had nothing to do with this, but I said she took away my I had lost my knees and she gave them back to me.
Okay.
Good.
Well, but you've got to tell her why you're going to see her.
Exactly.
Right.
I will do that.
Thank you.
Thank you.
Say
You're
hello.
welcome.
Say hello to that wife of yours, Debbie. She's doing a great job looking after you there,
Right.
Dave.
She is. She says I'm going to owe her in a little while when I get better.
Okay.
Oh, yeah.
That's-
And I live in Las Vegas, you know?
Yeah,
Thank you
great.
very much, guys. Thank you.
You're welcome. Okay. Gao Shan, tell us what's up. Hello.
Are you with us, Gaoshan? Your phone is muted. There you go.
Yeah, here we
Oh, I was across the room, so I had to come back to my computer.
How's that
Okay,
therapy
so
going?
so since December 1st, I had as Rick knows, some of my prior information, or most of it. December 1st, I had my first LA guard shot here in Portland, Oregon at OHSU. I then shortly thereafter proceeded to spend 4 months in Panama. I had my first PSA and testosterone test when I was there on the 18th of February. And the last PSA test I had, which was November 18, 2020, was 2.02. After the Eligard shot, it dropped down to 0.146. While in Panama, I had my second Eligard injection, and I had my PSA test done on April 30th, and a few days later, the results came back and it was 0.1. So it dropped from the top down about 30+%, which is the right good direction. I also started on May 3rd my radiation, total of 32 treatments, of which 23 are in the larger pelvic area, including lymph nodes, and the last 9 drill down to in the prostate bed. So for 32, I'll finish around June 16th, I believe. And then I have some follow-up continuing with the acupuncturist I go to and the homeopathy person that's helping me with a number of complements and supplements to improve everything. I also, back in August, I changed my diet from 50% plant-based to 95% plant-based, mostly raw, stopped alcohol 100%. And I think that's been very helpful. I haven't had to date any issues with the Eligard injections. I don't have any issues with hot flashes or muddled head, any pain issues. I exercise every day. So that's good. And so far to date, after 11 treatments of radiation at OHSU, I haven't experienced any issues with that whatsoever. So I think it's all positive. The next injection, as Rick recommended, is on June 1st, but instead of getting the 45 milligram one for 6 months, I'm going to stay with a 3-month injection. So it'll be June, and then early September or late August, and then the final one for this year would be in December. When I originally started this treatment, 3 different doctors I met with in LA, Dr. Vogelsang in Las Vegas, and then finally going to OHSU, they all recommend around 18 to 24 months of being on Eligard.
Well, sounds like everything's going in the right direction for you.
Once again?
It sounds like things are going in the right direction.
Yeah, I think so. I'm quite pleased. And in my discussions with Dr. Vuki, I talked about at what point would I need or plan to go on some other thing like Zytiga or something else. And she said, right now, I don't want to do that. Let's see how everything proceeds with the third and fourth injection and everything else that you're doing. And we'll make a decision at that time. Now,
Yeah.
one of the things is I also had a number of different scans, including a PSMA scan on October 2nd of 2020. And every scan or bone scan or PET, CT, MRI, everything came back negative, including the PSMA scan, no reoccurrence, no nothing. But for sure, we know that I have cancer somewhere. Hopefully it's still in the pelvic area, which is where we're doing the radiation.
Yeah, we should just clarify that this is treatment for recurrence, that Bocian had a radical prostatectomy. In
prostate removed in 2013, and it was fine for a number of years, but then it started climbing.
Bocian, you've never told us, how old are you?
I'm 67 now, be 68 on July 20th.
Okay. All right. So, well, I think you're making all the right moves. That's all we can say.
Okay, thank you.
John, what is practice of medicine like in Panama?
Actually, it's surprisingly good. I mean, there's a number of, in Panama City, there's a number of clinics, one called Panama Clinic. I went and had my injections and also my blood test done at a one called Punta Pacifica, which is tied directly with Johns Hopkins Hospital. And I guess there would be some type of sharing. It's very efficient. It's very easy to get an appointment. And any blood tests, you don't even need a doctor's approval. You just go and show up, pay your fee, and you'll get it. And within 2 days or less, you have the results, unless it's a testosterone test, which was a little bit longer. And a PSA test with no insurance was $24.99.
Wow. That's great. So
Jimmy's ready to go down. He's got the hat on. And
he's ready to go to Panama.
He figures it's going to be cheaper. Jimmy's ready. He's on his way down to Panama tomorrow.
Right.
Well, guys, before we close, I do want I'll echo what Rick is going to say. Is thank everybody for doing our survey.
Yeah.
The responses were fantastic. We had already a peek at some of the results, and I can say this group seems to be doing a good job for its members, at least according to what you tell us. So for which we are grateful.
And I think we need an acknowledgement here to John Ivory. Is he still with us or
Did
not?
John leave us? John left.
Well, he'll hear it on the recording because John not only was a huge help to me in designing the questions, because this is sort of close to his background, but he's now greatly helping Herb in terms of the analysis. So we're just very grateful. Listen, it's not just John. We are so grateful to all of you who volunteer for us. You guys are unbelievable. We are so fortunate to have such wonderful volunteers, and we're truly, truly grateful for it. And this is going to be special when we put these posters together and we exhibit them. I think we'll get a lot of kudos for it. So thank you, everybody.
What I'm actually surprised at, though, is we had nobody new tonight.
No one knew.
This is the first time in kind of almost as far as I can remember.
So
Statistical outlier happens all the time, Herb. You know that.
and I just want to share one thing with Don Price, who tells me it's pouring with rain, and Peter Kafka, who's down however 60 or 70 miles south in Colorado Springs, Peter says it's hailing down there. So you're
Higher
lucky.
up. It's higher up down there.
Oh, it's higher up. Okay. So you've got the hail, and Peter, is it still hailing where you are?
It stopped about 20 minutes ago, but there's flash flood warnings though. You getting flash flood warnings in Boulder?
No, but it's raining a lot. I mean, I wouldn't be surprised if they have flooding. I mean, it doesn't rain like this in Boulder ever, and it's just pouring and has been for the last couple of days. It's supposed to be tomorrow too. So.
Right.
All
Peter,
right.
remember the character
All
from
right.
Dick Tracy, Joe Bitsflick? Little rain cloud followed him wherever he went.
Yes, I remember that.
You remember her? Thank you.
Yes. Well,
All
guys,
right.
I'm
it's
the
been
oldest
great.
one
We'll
here.
see you all next week.
Next Tuesday.
All right,
Yeah.
thank you, Herb.
Thanks. Good
Okay.
night, everybody.
Good night.